chat. That way we can track for attendance because there is opportunity for credits from today's education session.
Awesome.
Thank you, Dr. Roby.
All right. Thank you, Michelle. And hopefully, if any of you guys are from the Canal Valley, it's the last Wednesday of the month, so the siren is going off right now. So hopefully, you guys can not hear the siren. It'll just go on for a couple more minutes. So anyway, just to kind of introduce myself for those that don't know who I am. So Mike Roby, I'm a family practice trained physician. I've worked with the Vandalia Health Network in the past. I was the Associate Chief Medical Officer there with the Health Network, and have done a lot of work kind of getting it started and getting it moving into the ACO and those types of things. And then I'm currently now the Vice President for our ambulatory and physician services down here at Vandalia Health, kind of in the South, in the CAMC area. So thank you guys for the opportunity today. HCC is kind of a hidden mystery, particularly for a lot of providers, of not really understanding what it's all about. But I hope that through today's kind of presentation, you'll understand the importance. And for those of you that are not providers but work closely with providers, maybe some very low-hanging fruits and different things that we can do to make sure we kind of capture really the severity of illness of all of our patients. And making sure that when we get more and more into value-based contracts, we are representing our patients appropriately in their utilization and their cost that they should be having. So with that being said, just kind of, there we go. Just kind of what we're going to talk about quickly today is just kind of give a brief landscape, because if we don't talk about the landscape, we're not going to understand the importance of what we're going to talk about. And part of that is the fee for service, the value-based care. And then an introduction into the HCC, a little bit of some changes in 2024. So if you've been familiar with HCC, these changes, you'll understand the impactfulness. And if you've never even heard of HCC, it will be important for you just to realize where we're moving as things are continually evolving in regards to risk stratification of patients and cost estimates of our patients. And I'm going to identify some gaps and kind of fill us in on ways that we can document perhaps a little bit better that you may be able to do yourself as a provider or share with your providers moving forward. So, you know, I do a lot of these kind of business and medicine talks, some with Marshall University and different things. And a couple of these slides are just slides that I think are kind of fundamental. And this slide right here, if you look, kind of shows it at where we are with fee for service, where fee for service is very prominent and value-based care is down at the bottom. And we're going to go through this transition period, and then value-based care is going to be on the top and fee for service is going to be on the bottom. And I always kind of think back to this slide that almost 15 years ago, I was involved with a home health company, and we were at a regional meeting. And I remember the owner of that company talking about this transition from fee for service to value based. And he was from Louisiana and down in the bayou, and talked about if he had one foot in each canoe and was trying to straddle between two canoes, that's a lot of the game we play between trying to figure out value-based and fee-for-service, and at what point do we start shifting more weight to one to the other. You know, this graph has been around now for probably 15 or 20 years, and I would tell you that we've just been stuck in the beginning of the revenue transition period now for 15 or 20 years. You know, we keep hearing CMS pushing more and more towards value-based. We're starting to see some of our payers working on contracts with us at a more value-based, and perhaps we're starting to get towards the middle of the revenue transition period. But as you guys know, we are still a very strong, heavy fee-for-service. A lot of our providers are purely based on fee-for-service, and a lot of what we do on a day-to-day basis in the healthcare world is still predominantly fee-for-service. But I really do think, you know, we're getting closer and closer every day to where value-based is really going to start taking off. And I do believe that the CMS has really started trying to put some time frames onto that. so that we can start really looking at what that transition and timeline does. And when you start thinking about that, that's really a movement, not necessarily to value-based care, but true population health management, right? So when we go from our current fee for service and we get to a truly value-based population health management, we're going to have to, cross this bridge into the other side of healthcare. And the ways that we're going to have to do that are with, advanced primary care, people-centered healthcare, because we're really looking at taking care of communities and taking care of people. And you can kind of see here, the one way to do that is really with what we kind of talk about, the triple or quadruple aim, which is where we're looking at cost, we're looking at outcomes, we're looking at patient satisfaction, and we're looking at provider satisfaction. And when we're really able to do that quadruple aim, that's when we're going to really get to that other side of population health management. So with all that being said, what does it look like when you compare a fee-for-service practice to a value-based practice? And I think one of the leading organizations out there is a company called ChinMed. And you can Google, you can read about ChinMed. The founders of ChinMed have actually written a book that really talks about value-based care. And the way that they've been able to completely go to value-based care is the only patients ChinMed sees are basically Medicare Advantage patients. So they have worked out with Medicare Advantage a strictly value-based program. So they are paid a set fee per patient per month, and then there's value incentives to that. So what does that look like from an operational standpoint compared to what we do now? So ChinMed is very successful at the value-based care. So I think they're a good example to look at what does true value-based care look like. So in a regular primary care practice, so I myself practice primary care in a private practice for many years, and I probably had close to 4,000 patients on my panel. It's very difficult to be able to manage those patients, but if I'm living in a fee-for-service world, I have to turn those many patient visits into being able to keep my lights on. Whereas if I'm more focused on quality, I can shrink that patient panel down to where I'm able to have a more intimate relationship with my patient. So we look at smaller panel sizes. So you're looking at more quantity with fee-for-service versus quality for value-based. Like I said, in today's world, providers are paid on RVUs. So for every widget that a provider does, there's some value to that widget and we get paid. But really in a value-based, your PCPs are salary-based with bonuses based on good outcomes and performances. In a fee-for-service, sometimes we're incentivized to just send patients to the hospital. There's really no disincentive to do that. But in a value-based care world, we're really incentivized to keep the patient out of the hospital and really focus on caring for them. And there's an emphasis on procedures and treatments with fee-for-service, again, because I, as a provider, get paid for the widgets that I do, whereas with value-based, it's not the same. We all live in a fee-for-service, and we all realize that there's a lot of uncoordination of care, relying heavily on our specialists, whereas like in the ChenMed world, the subspecialists are there to assist, but it's really the primary care docs that are leading the way. Higher profit is valued in fee-for-service, whereas high quality is valued in value-based care because that's actually what leads to higher profit. We tend to find a lot more ability for innovation within a value-based system, right? Because in a fee-for-service, again, it's very strict on how you get paid. But within a value-based, you can be a lot more innovative on how you use your resources to keep people out of the hospital, making sure that they're closing their gaps and those types of things. And I think one of the bigger issues is frequency of visits. So in a fee-for-service, I was lucky if I was able to see a patient every 4 to 6 months because I had to continually see more and more patients. But in a value-based, they typically are seen by their provider every month to make sure things are going in a good direction. So I think that kind of lays the groundwork for where we want to go next. So when you start talking about a value base, you have to have some kind of baseline of understanding who your patient is to be able to understand whether you've made improvements on that patient or whether you've been able to reduce their cost, right? So, you guys know that patient A and patient B in a practice sometimes are completely different. Patient A may be a 20-year-old with no medical problems, and patient B may be a 60-year-old with CHF, atrial fib, and diabetes. The utilization of the healthcare system is going to be much higher with patient B, and their cost is going to be much higher. So how does a payer such as Medicare or a Medicare Advantage plan able to understand which bucket your patient falls into, what their predicted cost is, and what their predicted healthcare utilization is? The way for them to do that is what we call HCC coding. So we've got to, again, have some way to do risk adjustments. That's what HCC coding does. We need to be able to account for all factors that impact the patient's costs and expected utilization, and need to make sure that we paint kind of a good picture of who our patients are. So to take one step kind of higher, the way the plans do that is something called a risk adjustment factor. It's called a RAF score. So a lot of times you may see that on reports and different things like that within your EMRs, and it says this is a RAF score. Well, HCC is a component of the RAF score. The RAF score determines, again, the amount of cost for that patient that's expected. So after calculating a RAF score, and I'll show you a graph here in a sec that really helps lay it out, Medicare can estimate that that patient's going to cost $10,000 this year. And that's kind of what they set their mark at. The RAF score is based on not only the HCC, but also patient demographics, such as age, sex, the residence of, like, do they live in a nursing home? Are they in an assisted living? And also their disability status. And that disease risk score is what we're talking about today, which is HCC, or hierarchical condition category. So to get an HCC score, CMS requires an encounter each calendar year diagnosed by an APRN, a PA, or a physician. And that's going to be important as we talk through this. Documentation must be accurate and support the diagnosis. So CMS does not just expect you to list diagnoses in a problem list. It actually expects you to document on each one of those. And also some conditions have values and some don't. So when we go through some of these examples, you'll see there's certain things that really it's just a way of the nomenclature, and some things have zero value and some things have more. And that's why physicians understanding what those factors are is so important. And we can add HCC scores together, and we can do multipliers. So I know that's like a whole bunch of verbiage, and it's kind of a wordy slide. So what I want to do now is just really walk through a couple examples with you. I think if we walk through this together, we're all going to kind of be leveled set of exactly what we're talking about. Okay. So we're going to look at a patient, an example, 76-year-old patient, not originally disabled, not on Medicaid, not end-stage renal disease, and not institutionalized, right? So remember, I was kind of talking about we need some of that additional data to create the RAF score. So the demographic RAF score for this patient, because they're not disabled, they're female, 76, and they're not institutionalized, is 0.448. So that's the first part. Now, the second part of the RAF score is going to be the disease burden. So let's take a look at a couple ways that a provider would have documented this in the chart, and what the end RAF score is, and how that relates to what Medicare expects to pay for that patient in a year period. So that patient comes into my office. I see the 76-year-old female, and she's obese. Her BMI is 42. So I go ahead and I document obesity, and I select that in my EMR and just select obesity. And then as we're talking, we go over her blood sugars and note that she does have retinopathy. So I put two more diagnoses in there. I put type 2 diabetes, and I put exudative retinopathy. We talk about her depression, And when I put in depression, the first thing that pops up into my EMR system is major depressive disorder, single episode, unspecified as a provider. I'm saying, yeah, that's close enough. And I click on it. So now I have 4 diagnoses. And I go ahead and add 4 more diagnoses over the visit. I put CHF, I put asthma. She has a pressure ulcer on her right heel that, again, I start typing pressure ulcer and I see it pop up in the EMR and I just click on the first option I have, and it happens to be the unspecified one. And then I think I'm really good with HCC coding, so I know to combine CHF and diabetes together. So I go ahead and add that one, and I think I've nailed this. I'm good. So this patient's HCC score, with the addition of her 0.448 baseline RAF because of her demographics, comes out to 1.029, which in Medicare conversion is about an annual cost of $9,000. So if this patient was in an ACO and I was trying to create savings for my group, this patient would need to spend less than $9,000 on healthcare in this calendar year for me to create savings. Now, let's go back, and now I'm a provider that just went through an HCC course, and now I really understand HCC coding. So I take a look, and instead of putting obesity, I know now that I have to be very specific with obesity, and I'm going to put morbid obesity. Look at the jump in HCC score from using a very specific diagnosis as compared to using a general diagnosis. So we now go from 0 to 0.23. Now, I also learned in my HCC class that if I were to combine diabetes with the complication, I again get a much higher. Now, this is a slide that is on version 24, or excuse me, version 20, the previous before 2024. And I'll show you that we're going to have some issues with diabetes moving forward. But for this example, it's a 0.318. What a huge increase. So instead of putting diabetes as one diagnosis and then retinopathy as a second, when I combine them as type 2 diabetes with diabetic retinopathy, I get a 3-time increase in my HCC score. With major depressive disorder, because I unspecified it, I just needed to put mild and almost a 4-time, well, you can't multiply 0 times 4, it's still 0, but you understand what I'm saying, a 0.4 increase in that one. Again, CHF is one of those ones that you don't really get much bigger bang for using a New York heart classification in that case. So still class 3, didn't really get a whole lot. You know, the previous doc, when the patient was admitted to the hospital, had put asthma on their problem list. And I just kept clicking it because that's what was on her problem list. But this is a 76-year-old smoker who clearly has COPD. I have a PFT that tells me that she has COPD. And I'm going to correct that diagnosis now. So instead of just putting asthma, because that's what the ER doc put in there when she went to the ER with influenza one time, if I correct that by what her PFT studies show, and she actually does have COPD, again, 0.328. Remember that pressure ulcer that I saw on the patient's heel? And again, I just clicked the first thing that came up on my EMR, but it's a stage 3. So I can see down, to the muscle. Then look at the difference there, 1.2 in an HCC score because of that. And then, I thought I was really good by combining CHF and diabetes, but now that I've added COPD, I'm also going to put CHF COPD combination. And now my RAF score is almost 3.5 times what it was initially. It's the exact same patient. There's no difference in this 76-year-old female. It all has to do with my specific documentation that I did. So now in the Medicare world, instead of having an estimated healthcare utilization for a year of $9,000, it's a much more accurate amount of $32,000. Okay. So hopefully that kind of makes sense, what the difference is and how we can specifically start coding some of these diagnoses to really make a difference and make an impact in the way that the payers perceive our patients. Because as we move from that fee for service to the value base, so we start walking across that bridge to population health management, it's going to be so important for us to be successful that our patients are accurately represented to the payers. Okay. And this is the huge difference. So we're talking, almost $23,000 difference in just one patient. So imagine if you had thousands of these patients. You had 100,000 of these patients. I mean, the Vandalia Health Network, I believe, is up to 130,000 lives now. If we're inaccurately coding and you multiply that by 130,000, that's millions and millions of dollars. That when we look at our cost and utilization, if we're not accurately representing that, then it looks like our patients are out spending tons of money. We're not taking good care of our patients and that type of thing. So I mentioned kind of briefly, and just kind of wanted to put this out there. This is kind of important, but it's not super important in the big scheme of things. It's been several years since they've made an adjustment to those values. So, where do they come up with these values? Well, these values are kind of a coefficient that allows them to figure out how much cost that patient's going to have. So you see, for instance, a pressure ulcer with a stage 3 is a really, really high HCC risk score. Well, think about that patient. If that patient has a stage 3 right heel ulcer, what does that tell you? That tells you the patient's probably immobile. It tells you the patient's not moving around. Their nutritional status is probably not very good. Then maybe their diabetes is uncontrolled. And it paints this picture of a really sick patient. And Medicare knows that a diagnosis like pressure ulcer right heel is probably a really good indicator that that patient is going to have high utilization this coming year. Okay. So they kind of then assign these points based on that. So when you think about just plain old type 2 diabetes, that doesn't really scream huge cost utilization, because in the minds of CMS, that just means, that could be their A1C is 6.5, right? But when you add to that diabetes that they have diabetic retinopathy, that right there tells you they don't take very good care of themselves, or they've had diabetes for a long time and they already have end organ damage, which means they're going to have higher risk of complications. So therefore you get a much higher score. Okay. Well, so what they've done is going back, we're now, this will be version 28. It will replace the current version 24. I have no idea what happened with version 25, 26, and 27. Maybe CMS just kind of wrote it down somewhere and never published it out. But we're looking at version 28 coming up in 2024. And it really kind of changes a little bit. It removed about 2,000, almost a little over 2,000 different diagnosis codes that no longer map to an HCC value. So remember how major depressive disorder unspecified, it didn't map anywhere, it was 0. Well, they've taken about 2,000 of these codes and mapped them back to 0, because what they've kind of figured out is that those codes don't really increase the utilization or the cost of that patient. Okay, so they've done all this digesting of all this data. They also, though, did add 268 diagnoses that they found kind of make a bigger impact. So how could we kind of figure out what this impact is going to be for us? And I think diabetes is probably the best way just to get a feel of what that means. So CMS will replace, again, version 24 with 28, beginning actually a couple weeks ago. And it's going to be phased in over the next 3 years. And the reason they do that is because as an ACO or as a program that has worked with a payer, we all have made assumptions on our current patients. Okay. So we have all decided whether to take risks, not take risk, from both our side as a provider, but also from the payer side, right? The last thing we want to do is just flip that around immediately all at once. So it's going to be kind of a phased approach, but what you're going to see is that about a 3% decrease in HCC scores. Okay. And we saw where 9,000 was 32,000. What that means when you reduce an HCC score by 3%, it's about $11 billion in Medicare Advantage reimbursement by 2026. So again, does this mean our patients are going to be spending $11 billion less because I changed some diagnoses? Absolutely not. What CMS is doing here is trying to readjust the values to reflect more accurately what the cost was. So if you were to look at this without kind of a conspiracy theorist mind, CMS is just correcting itself where it was actually estimating over $11 billion in costs when really those costs weren't being realized as these patients were going through this model. So again, this is even a bigger reason why, if we're already not coding well, we've really got to make sure we start coding well, because just because of the adjustments, we're going to start seeing a reduction in our estimated cost of our patients. And we all know very well that our patients are not likely going to spend less money. What this graph just shows you is kind of that transition period. So by 2026, we'll be fully flipped. We're going to start with about 60, 40, and then 40, 60, and then back to 100%. And again, the reason for kind of a slow approach to this is Medicare realized that a lot of organizations, including ourselves, make decisions on the amount of risk that they're willing to take based on these numbers. So if they were to go and just flip it all of a sudden, it's going to mess up everybody's calculations on risk and really could put a lot of payers and providers upside down. So kudos to CMS for taking kind of a slower approach to that. So you can see, when you look at the top 20 ICD codes dropped, so some of the things that they've kind of taken out are really the unspecified, right? So we used to get credit for like peripheral vascular disease unspecified. Well, not anymore, okay? You've got to be specific with your peripheral vascular disease. And there were almost 2.3 million counts of beneficiaries that had that diagnosis, okay? So now, if in the past we were documenting peripheral vascular disease unspecified, that's going to go to a 0 now, okay? So we've got to be more careful. Atherosclerosis of the aorta, there was a pretty significant decrease in the type 2 diabetes, and acute kidney failure unspecified. It's 0 now. It's completely wiped out. And as you know, if a patient's had acute renal failure, that's a pretty significant event and probably likely relates to some increased cost of that patient moving forward. So if we were just to pull out just the diabetes, the ICD-10s for diabetes, you can see here, 5.8 billion less in reimbursement. So almost of that 11 billion, almost 6 billion of that is just from the diabetes codes. And that's why I said I think we really need to pay attention to those. What they found is that, the diabetes itself did not correlate as much as they thought it did to the overall cost and healthcare utilization in some patients, particularly the less severe diagnoses, such as like just the type 2 diabetes and those types of things. So we saw a huge correction. So one of the areas that we should really focus on is making sure that we understand the diabetes documentation moving forward in those regards. This gives kind of a similar comparison from going from 24 to 28. Sorry, I was just kind of checking my time, making sure I was pacing good here. Disease coefficients for 24 to 25, and basically you can see down at the very bottom a 2.446 RAF score compared to a 1.014 in 28. So this would be what the difference would be in 2026. So this is full conversion over to V28. But you can see, some of the things like protein calorie malnutrition is no longer given any value. Toe amputation, which used to be a 0.5, no longer given any value. Diagnosis of diabetes and CHF is a little bit decreased. But for the most part, it has to do with a lot of codes just kind of being taken out. Okay. So what does that mean? Like, how does us as an organization of the Vandalia Health Network, you know, are we doing okay? Or, you know, and I could sit here and show you guys slide after slide after slide, but I thought one of the most just kind of impactful to kind of give you an idea of where we're at. So each one of these rows or columns, sorry, each one of these columns is an individual provider. Okay. And I removed names for matter of not incriminating anybody or having anybody thrown up here to be, you know, the person with the highest amount. But and again, this is only what we're able to pull out of some of our data. So this doesn't even include all of our docs and all the different places you guys are at, but it tells a story. Okay. And the story that it tells is that if I were to look at chronic kidney disease, we do not code chronic kidney disease well at all. So a lot of times we'll put chronic kidney disease unspecified, and we don't get into the level of the chronic disease. And this is just a perfect example of the amount of patients that we're missing an opportunity in coding an appropriate HCC score. If I were to put up diabetes up here, if I were to put atrial fib up here, if I were to put coronary artery disease, the numbers are very similar. So I wasn't going to just keep throwing graphs up, but I think just to realize, so where are our gaps? Our gaps are in the fact that we're not coding our patients with HCC scores. If you go back to my 76-year-old lady, right now, the majority of our providers are coding that lady at the $9,000 yearly utilization, 1.04 HCC score or RAF score compared to the much higher 3 RAF score. You know, our average RAF score, if you were to look at our ACO, is like 1.04 or something extremely low. And we all know we live in a state with the most unhealthy people. We rank in the bottom of, you know, the top 50 list of diabetes and obesity and heart disease and all that stuff. So how in the world, when we compare ourselves to other states and organizations, when we look at RAF scores, we appear to have very healthy patients. And I think we all would agree that for the most part, we do not have healthy patients. So I think this is just kind of, again, laying the ground. Hopefully you kind of have an understanding of HCC, RAF scores, how we calculate, what the importance is, and then a visual picture of a gap that we have in our ability to be able to document. So now that we've kind of presented the material, we've kind of identified the problem, I want to spend the next 15 or so minutes before we open for questions talking about what do we do? How do we fix this problem so that our patients are reflected accurately with our payers? So there's a couple of things we need to know. First and foremost, every single diagnosis needs documented every calendar year. So when January 1 hits, all of a sudden, according to Medicare, your patient is amazingly healthy with not a single diagnosis that's counted towards a RAF score. And over that calendar year, every time there's something documented on that patient, it will get added into the HCC calculation. But nothing from previous documentation will carry over. Okay? Number 2, it must be documented during a face-to-face visit. I still have very happy memories because the payer paid us very well in private practice, that when Medicare Advantage first came out, they would bring a form to us and they would say, hey, I'll give you $100 if you just fill out this form on this patient, just listing all their diagnoses. And we would do that. I'd have somebody in the office that would pull up the chart and we'd look through the chart and we'd list out all the different diagnoses that this patient had, whether it was chronic or stable or whatever. And then we would send that to the payer. And then the payer would input all that information and send it back to Medicare. And then Medicare was like, yeah, that kind of doesn't really work because you're not really addressing those problems with the patients. You're just kind of filling out a form. So let's not allow that anymore. So CMS's way of doing that was actually requiring a face-to-face visit. So every calendar year must have a face-to-face visit. You must document all coexisting conditions. So you want to make sure all those conditions are getting in there. And if you think about, well, what's the best way, and I'll put a plug in here, a shameless plug. What's the best way to see every patient once a year, do a face-to-face visit, and document all of their medical problems? It's an annual wellness visit. It's absolutely the best time to do it, because you know very well when they come in and they have a cold or a cough or something, you know, you don't necessarily spend the time to go back and make sure. Now, maybe if they have diabetes and it's going to affect your treatment of whether you give a steroid or something like that, you're going to consider that in your diagnosis. But for the most part, you don't get that opportunity to sit with the patient and talk through all of their issues. So again, I think an annual wellness visit is the way to make sure that we capture these HCC scorings. It's the way to make sure you have a face-to-face visit. Now, to get a little technical with some of the things, is to really look at watch your words. And you know, as I've looked at some of this and read some bulletins from CMS and different things, it's interesting how coders and providers think different. So particularly if you have coders that are looking at your note and pulling out some of the diagnoses and things, it really is important to make sure you watch, because history of, for coders, means that it's resolved. It's what they've been trained. And we need to use more words like compensated and remission. So what do I mean? So here's a perfect example. Paroxysmal atrial fib, patient has a history of paroxysmal atrial fib. We know as providers that, you know, that is an ongoing problem in most cases, right? They apparently, this patient, you know, and sick sinus syndrome, currently paced, on chronic warfarin because of the paroxysmal atrial fib, right? So it's not resolved. But from a coder standpoint, that kind of means resolved. But for us, you know, he's pacemaker dependent, device appears to be functioning normally. Again, kind of doesn't really give the story. So here's just some examples of what you want to think. So if the medical note says history of CHF, CMS interprets that as CHF has resolved. CHF compensated continued Lasix, they think CHS is active but stable. So it's all kind of about the word. Same thing with like AFib. But if you say AFib controlled on digoxin, they then know that AFib is still present. It's stable on active treatment. So again, just really kind of watching kind of the words that we use. Okay. Now, the other interesting thing, you know, we always think with EMRs, like, how can I forget a diagnosis? Like, I have an EMR, right? It's always going to be there. Well, back in 2014, I know that's a long time ago, but EMRs haven't really changed in the last 10 years, right? We have found that by using EMRs, physicians forget about stuff. Okay. So what this is showing here is physicians do not provide a complete and accurate listing of, and this was in 2014. So this was still ICD-9, but trust me, as a provider, this has not changed. We're on ICD-10 now. Cerner looks fancy and all up to date compared to Greenway or NextGen or whatever we were using 10 years ago. But all the conditions listed are chronic, yet only 17% of members had these diagnoses documented. Okay, so what does that mean? In that problem list, right, all those things were in there, but Optum only received 17% of those as diagnoses during calendar year 2014. And you can see, you know, when you first start using the EMR and you get that, of course, it's 100%. But then after the second year, you only get 17 of those diagnoses carry over. And then in the third year, it's even lower. So again, this is just, you know, that the importance of every single year, every single calendar year, that patient has to have these diagnoses sent to the payer. If they're not sent to the payer's got no idea that these things are still active, and they'll assume that they've been resolved. And that's what CMS does. Okay. So you can see our docs are not very good. So it's helpful, you know, to come up with operational processes within your clinic to be like, hey, here's our checklist. Let's make sure we're at our annual wellness visit time. Let's go back, let's look, and let's make sure we kind of cover everything. Now, I talked about making sure that we just don't list them as a diagnosis, but we also document what we're doing with each one of those. Now, when I went to med school, just a couple years ago, it was like 5 years ago I was in med school, because that's how young I am. We were taught something called SOAP. So subjective, objective, assessment, and plan. That works really good for a doc, but from a coder and from a CMS chart audit perspective, it doesn't really give the story, right? So I think SOAP notes are like really good for acute processes and those types of things. But when we start talking about kind of chronic care management, SOAP doesn't always really get us the need that we need. So there's another acronym out there. So instead of SOAP, we're going to talk about MEAT. And so if I have, for instance, CHF, so congestive heart failure, echocardiogram done 6 months ago, was reviewed and evaluated. So I'm monitoring symptoms and monitored an echo, evaluated with EF of 45%, patient BNP is chronically elevated at whatever, 340 or whatever. However, assess that patient remains stable and exacerbation, and then this is what we're doing. So refilled Coumadin or well, that doesn't go with CHF, but like refilled digoxin or refilled beta blocker or those types of things. So you kind of get that idea. So when you're down in the plan part of your SOAP note, it's really important to kind of throw this other stuff in there so that if you are kind of audited or whatever, you're kind of knocking off those check boxes of I'm monitoring this disease, I've evaluated it, I've assessed it, and I've treated it. Okay. And it just kind of gives the docs a way to kind of be able to put that stuff together in their plan there. And it gives the coders the ability that if they're dropping the diagnosis codes to really be able to help figure out what that looks like. So I think in summary, because I wanted to finish up with about 15 minutes for questions, so I did really good. So in summary, what we're really looking at, so here's some key takeaways. Okay, so if you remember nothing else, I hope you walk away from this presentation with at least an understanding of what HCC and RAF is. You don't need to remember what all the values are for different diagnoses. You don't need to remember exactly which diagnosis is because there are cheat sheets for that. There are EMRs for that. We've actually put together with the team at Vandalia Health a booklet. It's like, I don't know, 5-6 pages that kind of goes through some of these really common diseases and kind of gives you what are zeros and what aren't. So make sure you're kind of coding correctly. Some of the EMRs that you may be using kind of help that out too. So again, it's not really important that a doc remembers that ICD code E11.5 for diabetes, this has this HCC, but just having that understanding. The other big component is got to remember that the slate is wiped clean on January 1. We saw how diagnoses don't traditionally carry over through EMRs. We've got to make sure that we're dropping these diagnoses every single calendar year. Best way to do that, annual wellness visit. You're going to get a comprehensive visit with your patient. You're going to be able to close gaps, and you're going to be able to document those conditions. Remember now that it does have to be a face-to-face visit. 2, 3, maybe 4 years ago, this changed. So a lot of docs that are back when Medicare Advantage first came out, they may not understand the importance of it has to be a face-to-face visit with an APP, like a billable provider, APPs or physicians. Use that cheat sheet. So like I talked about, again, I don't expect you to remember every HCC code, but until you kind of get in the groove, review the cheat sheet for the first couple of patients. So you're like, oh, this patient has chronic kidney disease. I'm not going to just put chronic kidney disease unspecified. I'm going to take a moment and I'm going to figure out their GFR. I'm going to figure out what stage they are, and I'm going to document that appropriately. Once you do that a couple of times, it's going to become, particularly within your specialties or within kind of your focus areas, it's going to be there. And then just remember your verbiage, particularly if you're not manually putting the codes in yourself. If you have coders looking at things and different things, remember coders are trained that history of means it's resolved. Okay. So kind of keep that in mind. Again, particularly if you're in an organization where the coders are kind of pushing the specific diagnosis codes. All right. So that was, I hope, the most entertaining and fun-filled 45 minutes of your life. I do want to kind of no, a very good question, Dr. Lohace. So yes, so my understanding is, so the question was, when I say face-to-face, does telehealth count? My understanding is telehealth counts. It just has to be face-to-face is probably, I mean, I guess electronically you're face-to-face, right? But it does not have to be an in-person, but it does have to be an actual visit. And I think that is more in reference to going back to the old days where we would fill out forms for Medicare Advantage companies. Any other questions? You guys can either put them in the chat or you can unmute and ask as well. While you guys are hopefully typing into the chat, we will be providing these booklets that the team at Vandalia Health has kind of put together. So we'll be providing those in our interactions with you guys that you can share with your providers. You know, it's not so much stuff that it's overwhelming, but it's more stuff that it doesn't fit on a nice little card either. But I do think, yes, the booklet is digital, Dr. Lohace. So you can just kind of keep it as a PDF, or you can print it out, and I don't even know where I put it here somewhere, or you can print it out and just kind of keep it with you. It's going to be a nice little book. It's about 10 pages, but it clearly can be a PDF as well that you just have access to on your laptop. And it talks about the meat. It goes into like diabetes, chronic kidney disease, chronic lung disease, peripheral vascular, you know, depression, all those kind of real high common things. You know, the other thing that we're really kind of thinking through is in regards to helping our organizations figure out perhaps which codes need to be taken out of their EMR. This is just an example of something you may want to think about within your organization. Like some of these unspecified codes, I really struggle with, do we just remove them out of the EMR? So or at least somehow throw them all the way at the bottom of a pick list. So you think about depression is just the most easy one to talk about. If I put depressive disorder, a lot of times the very first one that pops up in my pick list in Cerner is unspecified. So I'm a busy clinician. I'm seeing 20 to 25 patients. I'm just going to click that top one. And the crazy thing is, it's probably like from a word standpoint so long that I'm probably not even really seeing the end of the sentence anyways, right? Like I just see depressive disorder and I'm just clicking on it. So, you know, we're trying to think through ways, if within our EMRs, there's ways to kind of prioritize the correct codes so that people can see those codes. This recording can be shared. We'll be pushing it out. I don't think it's available for CME post recording, but hopefully you found it worthwhile that people can take a listen to. And we'll put it on the Vandalia Health Network website. Anything else, guys?